Good morning, everybody. Welcome to the Stroke Coordinator Bootcamp series. We are excited to offer this 15-week course as a way to educate stroke coordinators in key components of their role, provide tools and resources to build and maintain successful programs, and to assist in building a large network of peers. Before we get started, we would like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For the question portion, at the end of the presentation, you may unmute your lines by pressing *6 or typing in the Q&A section of WebEx. Please note, you will only be able to claim your CME CE credits at the end of the 15-week series on September 27th. A copy of today's slides and handouts will be sent to you within a week of today's call. And for future webinar registrations, please visit www.HAATT.org/SWA quality. Today we have a great speaker who will be discussing clinical practice guidelines. Deb Motz is a Senior Director of Quality and Systems Improvement at the American Heart Association, specializing in stroke and AFib. Previously, she was a stroke coordinator for 17 years, 10 of them working for a single stroke certified center, and 7 working at the system level, managing 5 hospitals. Stroke is and has been her passion for many years. And now I will hand it over to Deb.
Thanks, Audrey. Today, the topic that I'm going to talk about are clinical practice guidelines. And I think we're going to start by doing some polls. Actually, I have 3 poll questions. And so while I'm doing the introduction, then Audrey will put up the poll questions. And she'll be able to put up the poll questions. I can't see them, but she can tell me what's going on with them. So the first question is, are you currently working in a certified stroke center or working on becoming a certified center within the next year? And if you could check yes, no, or not applicable. So just to kind of go over some welcome things, as Audrey said, this is actually the fourth week of our 15-week series. We've had some excellent speakers. Our first one was on the role of stroke coordinator. Our second of the series was on research and how to write abstracts to submit for the International Stroke Conference. And the third was anatomy and physiology. So things that you can do to actually, that will help the stroke coordinator better understand anatomy, physiology, and how it all works together with stroke. As Audrey said, these are available on the website, and you can review them at a later date. So just to kind of give you a little bit of history of how this all started, do we have our first poll ready yet? The results?
Yes, you should be able to see it on the screen here shortly.
Okay. All right. So just to kind of give you the idea, how this all came about was we at the American Heart Association was discussing what we could do to help stroke coordinators. What we've seen and what we've experienced is that stroke coordinators are frequently thrown into the position. They don't really know don't really know a lot about it, and just need some resources, because oftentimes you're put in the position, the person that was there prior to that is no longer there. So there's just a lot of issues with that. So quickly, the results for the first one is, are you working? Yes. It's 60, I can't see all the percentage. Can you read the percentages to me, Audrey?
Yes, so 62 out of 93 said yes, 5 out of 93 said no, and then not answered was 3.
Okay, so we're going to go ahead and put up the second poll question while I continue on. So the way this all came about was we started with a survey to see exactly what kind of things are stroke coordinators in our Southwest affiliate looking for. You know, what do you need to be educated on, and those type of things. So the survey was done. We then pulled together a group of stroke coordinators, representatives from each of our 6 states and the affiliate in the Southwest affiliate. The coordinators these coordinators have been very experienced. They've done a lot of presentations. Most of them have been coordinators for quite some time, although not all of them. We do have some that were on there a year or less. This committee then looked at the survey, identified some main topics that we wanted to talk about, and then went ahead to find some speakers for it. So that's just kind of some history of it. These webinars will be available on the internet for those that are not able to attend. And so they will be able, after the end of the series in September, we'll be able to go back and review, look at these, and still claim CEUs. So our second question looks like the poll was up. How many clinical practice guideline references are you required to adopt for your program? None. 0 said none. I see one clinical practice guideline. There was 4 people. A number for 3 or more, there was 13 of 102. And then for the depends on the type, it's 27. And then 58 didn't answer at all. So, so that's some interesting, and hopefully I will answer those questions for you. So let's go ahead and put up the third one, and it's just so I can get a little bit of background. And the third question is, how often are you required to review clinical practice guidelines? A is if and when you find a revised clinical practice guideline. B is you do not need to worry about them. They're not important. C is at least annually. And D is just before your survey visit. So if you go ahead and answer that. So now I'm going to continue on and just talk a little bit about my history. I know that Audrey kind of gave you a lot of it, but I started as a stroke coordinator back in 2000. I knew nothing. I knew absolutely nothing about it and was struggling to try to figure out exactly what this role was going to be, just like many of you are now. So it was really interesting. I was in a single facility. We got the program certified in 2004, and then every 2 years after that through the Joint Commission. So we were one of the early birds as far as, and this was in Iowa, so we were the first in our tri-state area, which is Nebraska, South Dakota, and Iowa, to obtain the certification. And then I moved to San Antonio in 2010, and I was the stroke coordinator for a 5-hospital system, which was very interesting. But my love, like Audrey said, is stroke and the stroke coordinator, and we really want to be here to do what we can to help. So looks like our poll is done. So if and when, so the first line, if and when you find a revised clinical practice guideline is when you review them. 4 people said that. 0 said you don't need them, they're not important. At least annual was 64, and just before your survey, 1. And then there were 39 with no answers. So thank you for the poll questions, and I will go ahead and get started on the actual presentation. So the title is Clinical Practice Guidelines What? Because that's exactly how I felt when I first started in the stroke coordinator role. I had no idea what a clinical practice guidelines were, and they really didn't seem that important at that time. But I've learned a lot since then. So disclosures, I have no financial disclosures except for I do work for the American Stroke Association, American Heart American Stroke Association. I have no disclosures for unlabeled or unapproved uses. So to get started, for certification programs in general, the majority of the information I'm going to provide to you today is the Joint Commission's primary stroke center. That was my basis that I used. And as you know, there's a lot of different certification levels. There's acute stroke ready. There is the primary stroke certification. There are now the thrombectomy capable stroke certifications and the comprehensive. So there's all different levels of those. But no matter what level you're looking at and no matter what governing body that you use, there are certain components that are a part of every single one of the programs. So the components, first of all, are standards. So every one, whether it's the Joint Commission, whether it's D&D, whether it's any other certifying body, have a list of standards or a booklet of standards. Those are kind of like your Bible. That's where you start to kind of look through and can do the gap analysis and try to figure out exactly where you are or where you need to be. The standards do change from year to year at times, and sometimes it seems like more often. So it's important to kind of keep up on those. The thing we're going to talk about today are the clinical practice guidelines themselves, and then the third component is performance measures. So no matter what or who is certifying you, these are three primary components of a certification program.
Hey, Deb, sorry to cut you off. Do you mind Xing out your poll screen on the right hand of the screen? Oh. It looks like a gray box for us. Thank you.
All right. Yep. So the objectives of the program today are the clinical practice guidelines. I'd like to give you an overview of what they are, how they relate to standards, and what are some of the requirements needed that surround the clinical practice guidelines. Second objective is describe the reason the evidence-based practice guidelines are important to the stroke patient. And then the last objective is to share a few of the top 10 cited standards from 2017. And those are taken from a webinar that was recently provided by the Joint Commission. And those are in my references. So if you'd like to go back and take a look, there was 2 webinars that were excellent that talk a lot about certification and, you know, how it's an important component. So so that is where the information is coming from. So first of all, I had told you that when I first started, I had so many questions. What is a clinical practice guideline? I had no idea. So understanding just what is it? That was where I first started. Then the next thing that came up is, are they important? And if so, why? Why are these so important? Because, you know, every program talks about clinical practice guidelines. Next question, where do I find them? You know, are they, how do you know if there's a new one, and where do you find them, and what do you look for, and, you know, all of those kind of things. And then as time went on, then the question became, so how often do I need to review these? You know, these need to be reviewed, I'm sure, and how often, and how do I know if they're current? And then what are the expectations? There are expectations for clinical practice guidelines, but exactly what are they? And, you know, how do you put that to practice? And then the biggest question was staff requirements, and which was the scariest for me, is how do you get the staff to know and understand exactly what a clinical practice guideline is? Because those of you who have been through surveys know that every surveyor will ask every single person, nurse that they talk with during their tracers, what is a clinical practice guideline? And how do you find them? Where are they located? So to start out, just to kind of give you a definition, I looked to the NIH and the National Center for Complementary and Integrative Health. That was published in 2017. And they defined the clinical practice guidelines as systematically developed statements to assist practitioners and patient decisions about appropriate health care for certain clinical circumstances. And that was quoted from the Institute of Medicine in 1990. So that's kind of a big overview of it. Some of the other components is that the clinical practice guidelines will define specific diagnostic and treatment modalities that are appropriate for whatever diagnosis your patient has and the management of that patient. Another thing is the recommendations are based on evidence from rigorous systematic review and synthesis of published medical literature. So these are scientific-based clinical practice guidelines, and they must be up-to-date and evidence-based. It's really important. So these guidelines are not fixed protocols that must be followed, but the intention of them is for the healthcare professionals and providers to consider exactly what is in the clinical practice guidelines, look at how you can implement those, and if there's any modifications or any reasons you don't want to, because it is patient-specific. Every patient is going to be a little bit different. Then you modify that treatment for those patients. But this is the guide. This is your baseline guide, and kind of oversees everything that you do with your program. And then it also identifies and describes generally recommended courses of intervention, but it's not a substitute for the medical advice. So back in the old days when we first started hearing about clinical practice guidelines, many of the physicians that I worked with anyway called it cookbook medicine, and they were very resistant. They did not want to use cookbook medicine, and they really did not think that was necessary. That has changed a lot over the years. And now many programs, not only stroke, but many others, are based on the guidelines. So specific for stroke patients, our stroke certification, the primary stroke center certification requirements are based in whole or in part of the most current recommendations from the Brain Attack Coalition, the American Heart Association, and the American Stroke Association, and the Center for Medicare and Medicaid Conditions of Participation. So no matter what program or what governing body you use to survey your program, all of them are based on the Brain Attack Coalition recommendations, because that is the most evidence-based scientific guidelines that are available at this time. So the next thing I'm going to talk about a little bit are what exactly are some of the standards and what are the requirements, and try to give you maybe a few helpful hints on things that you may be able to do to help you to be able to participate and to meet the criteria for these guidelines. So first, again, I'm using the TJC Standards of Primary Stroke Center Manual. And the first one that I looked at, I just kind of went through and did a search for clinical practice guidelines throughout the certification manual for primary stroke center. And this is the first one that I ran across was for program management, which is DSPR. So the standard is DSPR 6. And it says the program has current reference and resource materials. So these are requirements. These are things that have to be done. The standards, the elements of performance for these standards is that the practitioners have access to reference materials, including clinical practice guidelines in either hard copy or electronic format. So how are you going to do that? You know, you need these clinical practice guidelines are not like a 6-page document. These clinical practice guidelines are like 300 pages. So there's a lot of information in there. Practitioners are not expected to read it. So the staff nurses, they're not expected to read and to know all 385 pages of one clinical practice guideline. But instead, they need to have it available to reference it. So how do you do that? Well, you can print a hard copy and put it in a notebook and keep it on the unit. But again, these are like huge as far as the numbers of the clinical practice guidelines. So another way you might consider doing it is maybe putting a link on the computer in the stroke areas, so maybe in the EDs and the stroke units and the ICUs, and having a link where the nurse can go to that link and can click on the link, and it will open up the 300-plus document so that they do have reference to it. Again, when the reviewers or surveyors come around, they will ask every single practitioner to, first of all, what is the clinical practice guideline? And basically what it is the foundation of your program. Everything revolves around the clinical practice guidelines. So they will ask them that, and then they'll say, so show me, if you needed to look something up, show me where that is. And the nurses need to be, they need to be comfortable in being able to go and to find those things. So however you decide to keep those and make them available for your nurses or other practitioners in the stroke program, you know, is really up to you, but these are just some helpful hints that may help you. So the requirements specific to primary stroke or stroke center certification is that there's protocols and care paths, they're pre-printed or electronic documents. They're available in the emergency department, the acute stroke care areas, the stroke unit, for the acute assessment and treatment of patients with ischemic or hemorrhagic strokes. They also, reference materials and resources must be current and evidence-based. So how do you do that? You know, well, you follow the research to see if there's any changes. Typically, the clinical practice guidelines will be revised about every 5 years or so, and they need to be the most up-to-date and current ones, because when the surveyors come, again, they know what has recently been published, and they will be looking to see that you also know that and that you have those readily available and that you're working on putting those clinical practice guidelines into practice through your protocols and pathways and all of those things. They need solid evidence for the clinical practice guidelines, so they should be peer-reviewed. There should be randomized studies that support them, and again, they're a scientific background. So what are some of the sources for your clinical practice guidelines? Well, we have the National Clearinghouse from the AHRQ, which is at www.guideline.gov. That has been one of the primary resources for all the certification programs for many, many years. However, things are changing with that one. So the question is, so from there, and I'll go into that a little bit on the next slide, but from there, then where are you going to go? If they're not available here, where are you going to go look for them? So typically you'll look through your professional organization. So maybe the American Heart, American Stroke Association has a lot of the guidelines posted on their website. The American Association of Neurological Nurses has some clinical practice guidelines or recommendations that you can use as a reference. And, there's many other references. So whatever professional organization, if you're looking for something about diabetes, you can look through the diabetic recommendations. For cholesterol, you can look at the cholesterol recommendations and so on. So this is what I was referring to for the National Guideline Clearinghouse. I just noticed, and actually I just learned this not too long ago at a seminar myself, but that this website will not be available after July 16th of 2018. They no longer have funding to keep it up and running, so this site will be going away. So where else do you look? Well, I said you can go to the American Stroke Association website. You can go to the professional.heart.org website, /professional. So you click on professional, and then there's a little box that says guidelines and statements. And if you click on that, then you can search the guidelines and statements. They're all listed there, most of them anyway, but sometimes they're a little bit difficult to find on that website. So there is an app which is called Guidelines on the Go mobile app. It's free to download, and you can do it for both Androids and for iPhones. And this app it's an excellent resource. As the new guidelines come out, they typically are updated very quickly on this app. When you go into it, there's several different guidelines, but stroke is one of the many. But if you go into the stroke one, then anything that is like lit up like a pink or a reddish color means that there's something new in that guideline. So it will kind of help you it's a reference for you to review and to look at occasionally, just to see what's out there and if there's anything new. So standards. Another standard for the Joint Commission one is delivering or facilitating clinical care, which is DSDF. So one of the standards there is standard DSDF2, which is the program develops a standardized process originating in clinical practice guidelines or evidence-based practice to deliver or facilitate the delivery of clinical care. Under the elements of performance for this particular standard, the first one is that the selected clinical practice guidelines are evaluated for their relevance to the target population. So how inclusive are your guidelines? If you're treating patients that ischemic stroke patients, then of course you need guidelines for that. If you're treating patients that are intracerebral hemorrhage, then you need to be looking at those. If you have subarachnoid hemorrhage, then there's guidelines out there for that. So whatever your program treats are the guidelines that you really need to have adopted for your program, and that will be the basis of a lot of the order sets and pathways and those kind of things.
To make it more plausible.
Pardon, was there a question? You can star 6 to mute your line, please. The second element is the selected clinical practice guidelines are based on evidence that's determined to be current by the clinical leaders. So that means that your stroke committee, your medical director, your stroke coordinator, they all need to be reviewing the literature for new clinical practice guidelines and making sure that you have the most current ones that are available. So specifically for primary center certification, the primary stroke center has written protocols that are based on clinical practice guidelines, including protocols for emergent care of patients with ischemic stroke and protocols for emergent care of patients with hemorrhagic stroke. And again, these standards come right out of the disease-specific manual for certification for primary stroke center. Another one is the dysphagia screen used by the program is an evidence-based bedside testing protocol approved by the organization. So this is the one that's more difficult to find because there's not a lot of scientifically based dysphagia screens that are evidence-based. So this used to be one of the performance measures for the Joint Commission. It no longer is because there's not a standardized screen that everybody can use. So it's something that needs to be discussed. It'd be really good to have like a work group such as maybe your speech therapy partners and your committee just to kind of review what are you using for your dysphagia screen and then approve it by your organization and by your team to make sure that you're getting what you need. Another element of performance is the protocols for IV thrombolytic therapy, when indicated, are reflected in the order sets or pathways and utilized in the acute care of the stroke patient. So these kind of define these elements of performance and standards. Like I said, go back and review those one by one, and these are all the things that you need to have to build a successful program and maintain it. The time parameters for stroke workup are included in a stroke assessment protocol or the emergency department stroke protocol. You need to have some kind of protocol, whether it's through maybe the order sets or, however, you do that, but it needs to have the time parameters defined. And then they need to be monitored and shared with the group for process improvement. The program leaders and practitioners review and approve clinical practice guidelines prior to implementation. So how do you do that, How do you look at these? How do you adopt these clinical practice guidelines? How do you approve them within your own institution or facility? Where do they come from? These are things that need to all be considered. How do you evaluate these? How do you adopt them? How do you check for updates? Where do you look? How do you look for updates? So, through those programs, through that app is one way, but there's other ways as well. You need to have in place a process to update your protocols, policies, pathways, and order sets as the clinical practice guidelines change. Now, we know that can't be done overnight. It takes time to do this stuff, but you need to have a process in place. And then, where are they available? So we said before, whether you have a link to it, somewhere where your staff can find these is very important. You need to make sure when there are new ones, so say there's a new one that is, let's see, well, for example, there's a new clinical practice guidelines for acute stroke that was published in February. And now your survey is March. Well, you're not going to be expected to have all of the elements from that new clinical practice guideline and recommendations put into place immediately. The surveyors know it takes time, and it takes a lot of time sometimes to get these things updated and to look at them, make sure that everybody, or that they're being included, that the criteria is met for the recommendations. So the biggest thing that you can do during a survey when there's something new like that out is to make sure that your team is working on the new one. Make sure that your surveyor knows that that there are new ones out there, that they're available, you're working on it, that you have a process in place as far as how you look at implementing them, And then an expected completion date. When do you expect your order sets to be revised and updated? And like I said, it's not going to be overnight. It could be 3 or 4 months. But just so the surveyor knows that you are looking at them, that you're aware of them, and that you're updating your information as needed. The requirement specific to the primary stroke center is the protocols for emergent care of patients with ischemic or hemorrhagic strokes are reviewed for current evidence at least annually using an interdisciplinary approach. So that's another question. How are you going to do that? One way is if you have, if you're in your stroke committee, you could have maybe somebody assigned. One of the, maybe for example, your ER manager is going to be looking at the current evidence here and looking for new protocols, and then it has to be reviewed by the interdisciplinary team. So maybe you could bring some of the highlights from the protocols back to your stroke committee, share that, and approve it. The most important thing is make sure all of that information is documented in minutes somewhere, so that you can easily pull that information out to say, yes, we knew there was new protocols, yes, we're looking at it, and it was an interdisciplinary team that looked at it. It included our rehab people, our radiology, our CT people, whoever needs to be involved in that particular guideline needs to be part of this interdisciplinary review. Practitioners are educated about clinical practice guidelines and their use, and that's a really scary one. So how do you educate all of your practitioners? It shows here the requirement specific to primary stroke center is that the organization demonstrates that 80% of your emergency department practitioners are educated in primary stroke center acute stroke protocols. So how are you going to prove that 80% of your emergency departments have reviewed it? So there's different options or different ways you can do it, and they may ask you. They don't always. These are all just things that you could be asked to prove. So you may have maybe say a health stream thing. So maybe you publish, put a PowerPoint together on health streams, put that on your health stream, or send it out to the areas that are specific, especially in this case, the emergency department. Make sure that they know what your protocols are, and then they could go into health streams and sign a letter of attestation saying that, yes, I reviewed these. And that way you could pull a report maybe saying, showing how many people you have and how many actually have reviewed these. Now, this also includes the emergency department physicians. So it's not just nursing, it's the physicians and everybody else who cares for these patients need to do it. So maybe through your ER physician group, you could have something where they would need to sign off as well, and that, you keep record of that so that you can show that, this is how many ER physicians that we have in our facility, and this is how many, and more than 80%, well, 100% of them looked at this. So whatever it is, just being able to show that. So the program also must demonstrate evidence that it's following the clinical practice guidelines when providing care, treatment, and services. So required specific for the stroke center primary certification is the organization's formulary or medication list must include IV thrombolytic therapy medication approved by the U.S. Food and Drug Administration for the treatment of ischemic stroke, and are also backed up by your evidence-based guidelines. And number 6, the program implements modifications to clinical practice guidelines based on current evidence-based practice. So there again, I kind of already discussed that, but doing it through meetings, showing that evidence that yes, you've looked at them, yes, it's been interdisciplinary, and that your modifications, say they change, this happened to me one time, they changed the O2 SAT requirement from 92% to 94%, or vice versa. I can't remember exactly what it was, but our order set had the old one, as say it was 94% and it went to 92. So we were actually cited because we were not using evidence-based practice. The evidence said recommendation was the 92% O2 sat for the patient. So, you know, these little modifications, you really have to watch those to see what is changing and how are you going to implement that. So another standard, the element performance for the DSDF3, and that again is facilitating the care. The program is implemented through the use of clinical practice guidelines selected to meet your patient's needs. So that means if your patients, you know, we have to be able to show that we are looking one-on-one at our patients' health risks. What primarily do they have that's going to increase their chance of having another stroke, and make sure that they're educated according to their own needs. So there are clinical practice guidelines that directly address, these are the things that could be, that could increase the chance of your patient having a second stroke, and making sure that if that patient has diabetes, they're educated on diabetes, they know what an A1C is, you know, and they know the importance of maintaining that to prevent future strokes. So elements of performance for this is that the program establishes an interdisciplinary team that's based on the patient's assessed needs and direction from the clinical practice guidelines. 2 is the assessments and reassessments are completed according to the patient's needs and the clinical practice guidelines. And that's what we get caught on a lot. So the next thing, clinical practice guidelines requirements. So program-specific eligibility. So all programs seeking primary stroke certification are expected to demonstrate their application of and compliance with a set of clinical practice guidelines, one of which may include the guidelines and recommendations published by the AHA-ASA relevant to the stroke patient being treated. But again, there are other references as well, as long as they're peer-reviewed and research-based. Then that's not, the AHA-ASA is not the only source to obtain these guidelines. Clinical practice guidelines are found in the literature under many names. Some call it practice parameters, some say practice guidelines, some say patient care protocols, some say standards of practice, they may be clinical pathways, they may be care maps, and so forth. But in all cases, they have to be evidence-based and effective for the targeted patient population. So here's a question. So care plans, care paths, plus pre-printed order sets equal a clinical practice guideline. Is that true or false? So actually, they are not the same. The care plans and care paths and the pre-printed order sets are not the same as the clinical practice guidelines, but instead they are tools that show how you have implemented your clinical practice guidelines that you chose. So these are this is the way you're going to show that you are implementing them. So you'll have the recommendations in your care plans, in your pre-printed order set. The recommendations will follow the clinical practice guidelines, but are not necessarily the same. So these are it's the tool. So why are evidence-based clinical practice guidelines important to the stroke patient? Well, I think for me, if it was my family or my parent or whoever, my friend that had a stroke, I want to make sure that they are utilizing the most up-to-date care and the treatment. One of the basis for certification and for clinical practice guidelines is that we want to be able to treat every single stroke patient the same. As far as, you know, we want to look at the same things. We want to make sure that they have a thorough exam, that we can identify maybe the type of stroke, that we can get them on the appropriate medications that are recommended for them, and that you can maintain to help prevent future strokes. So it's very important because these are the most up-to-date current things that drive your program and produce the best outcomes. So what are the most frequently scored standards for 2017? And this was in that the TJC webinar. Again, I would encourage you, if you were not a part of that or looked at it, I would encourage you to go back and take a look at that webinar. Actually, both of them. They're excellent. But the number one citation, oh, wait a minute. First of all, excuse me, I'm going to go back one. So can you put up the next poll question, please, Audrey? All right, so the poll question is, 2 of the top 10 most frequent cited standards for 2017 are related to clinical practice guidelines. Is that true or false? 2 of the top 10 most frequently cited are related to clinical practice guidelines. True or false? So if you would answer that poll. I just kind of want to see what people said before I get on much further. Do we have results for this one?
Yes, give me 5 seconds.
All right, there it is. So 72 out of 128 say true, and 4 say false, and 52 had no response at all. So actually, true is the right answer. And I'll show you why. So number 1 citation for 2017 was, the program is implemented through the use of clinical practice guidelines selected to meet the patient's needs, which is DSDF.3, which is what we had just gone over, all of those standards. 43% of the citations for 2017 was related to this particular clinical practice guideline. 43, that's a lot. So remember, if it was not documented in the medical record, then it did not occur. The number 2 citation for 2017. The program develops a standardized process originating in clinical practice guidelines or evidence-based practice to deliver or facilitate the delivery of clinical care. Again, that was the DSDF2 that we talked about. And 24% of the citations for 2017 was related to this particular clinical practice guideline. So what can you do with these things? Well, you know, it's important that, well, here, let me go back. So developing or originating. So what are some of the things, oh, wait a minute. Sorry about that. So the clinical practice guideline rules. So when the surveyor comes in, then some of the things that you need to have available is information about the discussion and the approval of the clinical practice guidelines are documented. So again, in your meeting minutes or however you might want to document those, but you need to have that available to prove that you have looked at them and that they have been approved by the committee, interdisciplinary. There should be a process to review and update them that is being used. So being able to discuss this, and this can be done through your data tracer. So when you're talking about your data tracer, you can also include how you review them, how do you update them, that there's a process to update all the protocols, all the order sets, all the policies with the most current clinical practice guidelines, and education of all department staff, practitioners, involving in the care for the patient, including MDs that admit as well as provide consultative services. So that was in, within that webinar again. So, you know, some of the things you can see why, you know, what it's saying that you have to follow the clinical practice guidelines. So, for example, if you are not monitoring your patient post-PPA with the vitals and neuro checks every 15 minutes for 2 hours, every 30 minutes for 6 hours, and every hour for 24 hours, then you miss one of those assessments, then you fall out, and you can be written up for that. So anything that the guidelines say, it says that we have to do a dysphagia screen. So if they cannot find evidence on the chart that the dysphagia screen was performed, then you can be written up for that. So you can see how this is like a high reason as far as why the clinical practice guidelines are so important and they really do drive your entire program. So going back to the beginning, questions, challenges, clinical practice guidelines. So first of all, hopefully you have a better understanding of just what they are. You have a better understanding of why they're important. They're important because you have to have it for certification, and you have to be following them, and it's just important for the overall care and outcomes of your patient. Where do I find them? Gave you a couple different resources for those, but again, look towards your professional organizations to help to determine, what is the best one. How often do I review them? Well, at least annually, and the medical director and stroke coordinator or whoever should be looking, watching for them, checking the sites every once in a while, because it's not going to just drop in your lap. You'll find out, the hard way sometimes that there have been updates to them. So just kind of monitoring every so often, checking into it to see if there's anything new out there. What are the expectations? Well, the expectation is that you follow the clinical practice guidelines. So if they tell you to do something at a certain time, that is documented in a timely manner, as it should be, and that you're educating your patients and that they know their risk factors and all of those things. That's all part of the expectation, is that you are following these guidelines. And staff requirements. That's the scary one. So, how are you going to make sure that your staff know about it? Well, one way to do that is you could have, we used to call it clinical communication. So when there was a new clinical practice guideline, we would put the title of it in there. We would maybe just put some high points as far as these are things that have changed, and then send it out to everybody and have them sign a sheet that said, yes, I looked at this, yes, I reviewed it, and that way you have, you have proof that that was done. Typically when a surveyor comes around, they're going to ask you, or whoever they talk with on their tracers, whether it be speech therapy, rehab, PT, OT, nurses, physicians, they're going to want to see the patient file, or the staff file, showing that they have been educated on these things. So you can have this information within their file so that it can prove that, yes, whether you print a HealthStream document or whatever, saying that, yes, I have reviewed this, and yes, I do know what they are. So that's the end of my presentation, and I hope that I was able to answer your questions. Here's some great references, and I would like to open it up for questions.
Hey, everybody, you can either press *6 to unmute your lines or type in the Q&A section of WhatsApp. Hey, Deb, we did have an answer come in. They're asking if they need a separate CPG for endovascular treatment, or will the AIS guidelines cover it?
The acute ischemic stroke guidelines should cover that. I'm not aware of anything at this point outside of that is specific to endovascular, but again, keep watching for those, because there's so much research going on with those, with endovascular and LVO right now, that I foresee that there probably will be more, but your acute ischemic stroke guidelines should cover that. Any other questions? *6 to mute or unmute, or type it in the box. I know you have burning questions about clinical practice guidelines now. Come on.
All right, we got question number 2. Do you have a recommendation for any CPGs better than others?
Better than others? I think, what you probably really need to do is take a look at exactly what your program covers. So if you're an acute stroke-ready hospital, then more than likely you're not going to be treating hemorrhagic stroke patients. So your main guideline is going to be, the most comprehensive one will be your acute ischemic stroke guideline. However, if you're a comprehensive center, you're taking care of all of the different kinds of strokes, the hemorrhagic, the cerebral hemorrhages, the subarachnoid hemorrhage patients, the acute ischemic, the TIA patients. Don't forget to include TIA patients, because those are very important. It always bothered me when I was a nurse and was stroke coordinator, and I would hear one of the staff nurses say to me, well, it's just a TIA. And I'm like, you know what? That TIA patient could go on to have a huge stroke. And wouldn't you feel horrible if we didn't work them up to try to figure out why they're having these symptoms and, you know, what happened and what can we do to prevent that big stroke from occurring? Thank God you're not disabled. How can we prevent you from having that stroke? So don't forget the TIA patient. There are clinical practice guidelines for prevention. I think there are some on community education as well, possibly. I'm not positive about that, but I do know that recently, and I just heard this, that there are some hemorrhagic stroke guidelines in the Stroke magazine. So Stroke magazine is another one that you can take a look at, but it's a relatively new one that's looking at performance measures specific for hemorrhagic patients. So, you know, take a look out there, see what's out there, and monitor it.
All right, Deb, question number 3. A participant is using adult stroke management in dysphagia CPGs. Should there be more, or is that enough to qualify for certification?
I'm sorry, say that first part again.
They are using adult stroke management in dysphagia CPGs.
Mm-hmm. Yeah, no, that works for it.
Or is that enough to qualify for certification?
Yes, I mean, that's enough for stroke education. As far as your staff goes, I think as far as your staff goes, if I'm reading this right, or understanding right, the staff, you could show that through, you know, and it could be a one-time thing. I mean, if you have a lot of stroke patients and you're doing dysphagia screens 10 times a day or whatever, you know, you only need that original, making sure that the staff is educated on what exactly you do for your dysphagia screening and how do you interpret it and what do you do with those results. So, for example, if the patient fails, what are you going to do? Well, you're going to keep the patient NPO. So, you know, having a protocol based on that, you keep your patients NPO, you're going to notify speech therapy. You know, can you rescreen the patients if they seem to be getting better? I mean, those are all part of the things that you need to consider when you're putting those protocols together. But again, just reviewing what's out there as far as dysphagia screening and utilizing the experts that you have within your team. You know, the speech therapy professionals, they have a lot of information and can really help to guide what you should be using for your dysphagia screen and why. But when they do come around, then you're going to want to be able to have references that show how did you choose this particular screen, if that makes sense. I hope that makes sense.
Another question, are non-certified hospitals held to the same standard as certified hospitals?
So the answer to that, the real answer to that is no. However, if you're treating stroke patients, then you should be following the clinical practice guidelines. It's evidence-based. You have the best outcomes. So anything that you can do to meet these requirements is what needs to happen, because you know, the stroke patients, they need to have great outcomes. And with the new LVO and things like that, it's important for you to be able to determine, first of all, is this patient a large vessel occlusion, and could this patient have a thrombectomy? Because, you know, we've seen patients come in that had an NIH stroke scale 24, you know, the gaze preference, completely paralyzed, unable to speak, go for their thrombectomy, and they come out completely normal. These patients would be in a nursing home. You know, they would not have a good life. They would not be able to function well, and they would be in a nursing home bound. But now there are things that can be done. They're like miracles. It's amazing when you see that patient wake up who couldn't move and wave at you or lift their leg or start talking all of a sudden. So it's really important that you know what the protocols are, that you know what the guidelines are, that you know what the treatment options are, so that every patient can get the best possible care available to them.
Great. Well, thanks to everyone who asked questions. If there are no more, we would like to thank Deb Mott one last time for presenting over clinical guidelines. A couple reminders before signing off. Please note you will only be able to claim your CE credits at the end of the 15th series on September 27th. And a copy of today's slides and handouts will be sent to you within a week of today's call. If there are no more questions, thanks guys, and we'll see you next week.
Thank you.